So we're going to get underway with our first presenter. I'm delighted to introduce Dr. Daniel Rayson, who is a medical oncologist in Halifax, Nova Scotia. Dr. Rayson is going to provide us with an overview of NETs in his talk, NETs 101 for the newly diagnosed.
Thanks very much, Jackie, and thanks for everybody for being here. And good to see some representation from Atlantic Canada, some old friends. It's great to see you all. I can't see anything in these lights, so Dan, you're going to have to stand on the table with the folders for me, okay? So I was asked to talk about NETs 101, and for everybody who has been newly diagnosed, for those of us who see you for the first time, that initial consultation is one of the most challenging points in our relationship, right? It's a time of ultimate anxiety, ultimate fear, ultimate questions, and the questions come at us fast and furious. And part of our job is to try and answer them in as clear and honest a way as possible, realizing there's a lot we don't know. So what I tried to do with this talk is break this down into 13 questions you might be wondering about, all right? And hopefully I've got them all straight. And my job here is not to let anyone fall asleep, because you've got a big day ahead of you. So if you fall asleep with me, all the rest of my colleagues are in big trouble. So question number one, I have a what? A neuroendocrine tumor, right? Now, most of us walking around in the general population have an understanding of breast cancer, of colon cancer, of lung cancer, but there are very few people walking around with a concept of what a neuroendocrine tumor is. Now, our pathologists, you're going to hear from our pathologists, but this is what this is. And most of you have tumors that look like this. And our pathologists are quite good at telling us this is a neuroendocrine tumor, because you've got these funny large cells with this what we call salt and pepper stuff in the middle. What's amazing and what links everybody is that this is a system in the body that is incredibly important, because in those cells are little packages of hormones and neurotransmitters, which are chemicals that regulate almost everything we do almost every second of the day. It's a system. And think about it, to get a city like this to have real estate prices go up by 30% every year, apparently without limit, you need a huge infrastructure, right? You need a road system that works. You need an electricity grill. You need people to pick up the garbage. You need a system to develop, to sustain. And we all know what happens when the garbage guys go on strike or the buses don't start running properly. So the neuroendocrine system is a really finely tuned balance to try and keep all our bodies in balance, whether we're sleeping, whether we're running away from an enemy, whether we're having a bowel movement. It's involved with all our basic processes. It's a system. And it's incredibly diverse. And this is why in this room we have people that have neuroendocrine tumors that started in different places in the body. And a lot of the information you'll hear today may be very relevant for some of you, may be less relevant for others, but just know that everything you hear links together because this is a common system. So this cartoon gives you a sense of the diversity. So these tumors and these cells can be found in the brain, in the kidneys, in the heart, in the gut, the pancreas, the skin, everywhere. And each of these areas have their own characteristics, so they control different functions, like blood pressure, like how the bowels move, like blood sugar control, all right? So you're going to hear a lot today about different hormones, different syndromes in relation to neuroendocrine tumors, because this is what neuroendocrine cells do. They regulate and they talk to each other and they talk to our body to tell things to work properly. Now, because of this, these tumors can start anywhere, essentially. The most common places they start are in the small intestine, the pancreas, the lung, but the skin, the adrenal glands, the kidney, we can find these tumors everywhere. And that's what makes this such a challenging disease, such an interesting disease, and makes it difficult to tie all the information up in one clear package for every single patient. And we'll come a bit to the confusion about all this in a few minutes. Okay, question 2. Why was it so confusing when I was diagnosed? right? I'm sure if we just started talking as friends, the stories that would come out would be really overwhelming in terms of this issue. So the diagnosis is often poorly communicated when it happens. And that's true for a lot of cancers, but probably more so with neuroendocrine tumors. It often comes out of the blue, right? We have people understand screening mammograms, and if there's something suspicious, there's another test to confirm it, or to rule in, or to rule out. We have that concept. We know that fecal occult blood testing can early detect colon cancer. We have none of these tests for neuroendocrine tumors. So the diagnosis oftentimes come like a brick falling from a plane, or a bag of ice coming from a plane. It's a shock to everybody. It's poorly understood by the general medical community, and you'll hear a lot about that, I think, as the day goes on. The information is often incomplete. You'll hear from a lot of my colleagues about all the work that goes on behind the scenes to make sure we truly understand what this disease means to you. But when the diagnosis first happens, when the pathologist just looks at the cells under the microscope, there's a lot of further information that needs to come before we're able to really tell a patient exactly what this means. And there's a gap between the diagnosis and all the anxiety and the fear and the collection of all the information that's needed to really give you the information you need. And in that gap is a lot of confusion. And it all happens in the indiscriminate terror of a cancer diagnosis. And I don't need to belabor that for everybody here, I'm sure. And sorry for the back, you won't be able to see the bottom of these slides. But one of the biggest issues we face as new patients coming through is there are two spectrums. Either there's an initial diagnosis, there's a catastrophization, right? That you need chemotherapy yesterday and that time is very short, which may not be the case at all, as many of you know. Or there's a minimization. This is just a neuroendocrine tumor, it's benign, it's never going to hurt you, which also is not quite true, which leads to, again, further confusion. Next question, how common is this? We all know this is not a common problem. The best information we have is from Ontario, from Dr. Singh's group in Sunnybrook in the Cancer Registry in Ontario. A couple of numbers. In 2009, there were over 62,000 cancer diagnoses in the province of Ontario, but less than 600 or less than 1% were neuroendocrine tumors. So it's not common, even though you're a very powerful group and the awareness is rising dramatically. But as you heard yesterday from one of our colleagues, because patients with neuroendocrine tumors do so well for so long in general, there are more patients walking around, living normally, working, raising their families with neuroendocrine tumors than patients with pancreatic cancer, stomach cancer, esophageal cancer combined. So you're a powerful force in numbers. It's uncommon, not rare, but there are lots of you out there. And this is a great forum to connect on all sorts of issues. How did this happen? And is it hereditary? I cheated there because I only have 15 minutes. I don't want the red folder. So there's two questions in one. So how did this happen? And for the vast majority of cases, we simply don't know. We're incredibly ignorant about the source, the cause, the triggers in relation to this disease. And is it hereditary? It may be in certain families. You'll hear later today that there are a number of clearly defined syndromes that do increase risk of a whole number of neuroendocrine tumors. But we don't know how many patients with neuroendocrine tumors get referred to medical genetics for genetic counseling or testing, how many should be, and how many times we're missing a potential hereditary story. And maybe you'll hear about that a little bit later. When did it start? We don't know. So you remember as kids when you were counting rings on a tree to see how old the tree is? And when we dig up in Alberta dinosaur bones, we can do carbon dating to figure out when this beast lived. We have none of that for neuroendocrine tumors. And to be honest, we don't have any of that for most cancers as well. So we don't know. Why wasn't it diagnosed sooner? And that, again, will be a common theme, I'm sure, as the day progresses. So as many of you know, many cases grow very slowly without any symptoms or any hormonal syndrome over many years. So it's a classic percolating issue that goes under the radar, sometimes for years, sometimes for decades, again, because we don't know when this starts. before something triggers a diagnosis, or the disease is found completely by fluke in the process of getting a test for something else. And I'm sure there'll be heads nodding here. It happens very commonly. Those with symptoms are often diagnosed and treated for other benign conditions for years before anyone would ever think of a neuroendocrine tumor. Based on a number of factors, and based on the fact that the syndromes that can come with neuroendocrine tumors can mimic all kinds of other sort of normal issues. And again, we'll talk about that later today when we talk about the different syndromes. The most sensitive tests are not necessarily easily available or easily thought of in Canada. So it's not like every small hospital has an Octria scan, never mind the more fancy gallium scan that you'll be hearing about later. And there is an issue in this country about having access to some of the tests that are needed to more accurately or completely diagnose neuroendocrine tumors. And historically, again, sorry for the people in the back, when doctors hear hoofbeats, right, it's horses, not zebras. And that's a huge gap. But I propose and I submit to you, and I think my colleagues would agree, it is really changing through the efforts of CNETs, through the efforts of a lot of us who keep talking about neuroendocrine tumors almost ad nauseum, to be honest with you. But with a smile. I didn't mean that. With a good, because this really is the most interesting area of medical oncology for many of us. Can it be cured? Yes, but surgery is the only curative modality. So I don't know if you can see this. So this person at the top, your top left, excuse me, has a small bowel neuroendocrine tumor. That's that red circle is right there. And that potentially is surgically removable and curable, and also has 2 small liver metastases, which also are potentially removable and potentially curable. And you'll hear a lot today about the integration of surgery and different types of surgical approaches to try and optimize cure rates, or at the least, to try and remove as much as possible, called debulking. At the bottom, though, you have a patient with a massive liver that's really completely filled with neuroendocrine tumor disease. And that patient, there is no curative potential for this particular patient. So there's a huge spectrum. Again, it's never one size fits all. It's never one story fits all. But surgery is really the only curative treatment we have right now for neuroendocrine tumors. What is this Ki-67 I keep hearing about? What on earth is that? So it's a test that's done, that should be done for everybody's tumor, and it's available, easily available, it's not expensive, that tries to grade the tumor by getting a sense of how many cells are active. And at the bottom, for those of you who can see, there are 3 grades, and you just count up the brown spots, and those brown spots are the active cells, excuse me. And the percentage of those active cells compared to the other cells defines a Ki-67 index, or the proliferation. And we use that information almost daily for all new patients diagnosed to try and get a sense of what we expect the disease to do over time. So you'll hear a lot about this, about Ki-67. You'll hear a lot of people talking about grade, and this is what it means. It's a lab test, not expensive, should be done for every single neuroendocrine tumor. Is this why I've been feeling poorly? Well, sometimes. So again, sorry. There we go. Again, on your top left is that patient I mentioned with that mass in the middle of the guts, basically. And this fellow, about once every year and a half for about 10 years, had a day or 2 of abdominal pain. It would come, it would squeeze, he'd throw up twice, it would go. And in the year before the diagnosis, he was having this monthly. And it was that escalation of symptoms that led to the diagnosis. And looking back, this probably was the story for the past decade. But again, under the radar. This other fellow on the top right is a patient of mine who was a postal worker in Dartmouth, Nova Scotia, delivered these huge bags of Canada Post mail up and down stairs in Dartmouth, in the apartment buildings in Dartmouth, every day for 20 years. had 3 hours of a pain in the right upper quadrant, right upper part of his belly. Someone told me, you should go to the emergency room and get an ultrasound of maybe your gallbladder. That's what they found. His liver was completely full of neuroendocrine tumor. And he had not a symptom, perhaps for decades. At the bottom, and again, I apologize for those in the back, there's basically a tiny yellow arrow going to a tiny, tiny spot, okay, that's measured about 1 centimeter. And this patient had years of strange spells where she would get sweaty, dizzy, hungry, nasty, and nobody could figure it out. And suffered tremendously because she never knew when it would happen. She never knew it could happen when she was driving, when she was with the kids. And it turned out she had a tiny 1 centimeter pancreatic neuroendocrine tumor that made too much insulin, an insulinoma. So I share these cases with you just so that we can broaden the discussion to get a sense of the diversity and the spectrum of this disease and how each of you will have your own story. Some will be constant, and there'll be a group that has a very similar picture, but many of you will have your own unique stories. And our job is to try and figure out what is related to what. A couple of other situations. So this lady with the red cheeks was told first she had rosacea, then she was postmenopausal, then she drank too much before a diagnosis was made of a neuroendocrine tumor with something called carcinoid syndrome, which has the common symptoms of flushing and diarrhea. And she'd had this for at least a decade, okay? And over time, what can happen to these patients is with high levels of this hormone, again, on your top right, this is a heart valve, okay? It's very thin. You can almost see the blackness through the valve. That's the way it should be. But over years, with this patient, that heart valve became very thick and white and stopped working properly. And that's one of the potential problems that can come over years, that can arise under the radar with carcinoid syndrome involving the heart valves. Okay, so I hope I've given you a sense of the spectrum and why this is such a difficult disease to categorize for everybody, and why the information that you hear sometimes comes from all over the place. Now, a big question, do I need chemotherapy and radiation? Most of us think when we think of cancer, we think of the worst, our worst treatments. When we tell patients they do need chemotherapy and radiation, that is a very difficult discussion in many different ways, as you can all imagine. And I know many people here know that in general, classic chemotherapy and radiation isn't usually part of the treatment process. If you do, it's completely different. And again, you're going to hear a lot about this, but we've got a huge plate of potential treatments. You'll hear about somatostatin analogs, and many of you have experience with them. You'll hear about a whole bunch of liver-directed surgeries or therapies that can be done by our surgical colleagues and sometimes by the interventional radiologists. You'll hear about ways that we can get into the blood supply of the liver, for example, and deliver treatments by either blocking the blood supply or delivering liquid radiation through the blood supply directly to the tumors. You'll hear about PRRT, which is a form of radiation that basically is delivered intravenously and that targets specifically areas of disease that express something called somatostatin receptors. You'll hear about that a lot today. And you'll hear about some of the new medical treatments that are very different from classic chemotherapy. They're more targeted, they're more specific, and even some of our chemotherapy drugs, our classic chemotherapy drugs, there are new treatment options for neuroendocrine tumors, and they come in pill form. So it's not the scary intravenous hair loss 666 chemotherapy. And for all of our patients at any stage, any one of these treatments might be relevant. All right, so patients may shift from this to that, back to this, then over to this, then back to this. And many of you, I think, have had this experience. And all the way through, The only way we're going to make any further progress, and the progress has been enormous in the past decade, probably for those of us who trained in an era where there was no progress in neuroendocrine tumors, the past 10 years has been almost astounding. Clinical trials, right? Clinical trials are such a key component of everything we do in oncology, and all of us should be asking, is there a trial for me? Is there, and why? And if not, why not? What is my prognosis? Common question for all of our cancer patients, as you can imagine. More difficult to answer sometimes for neuroendocrine tumors. And it's highly variable, okay? And I'm going to go through some of these. So first, the extent of the disease, where it is, how much it is, and whether or not it can be completely removed. Because remember, surgery is the only thing that really, truly cures this. The site of primary origin. So prognosis sometimes vary, depends on where, if it starts in the pancreas versus the small bowel versus the lung. The symptom burden, how sick or how not sick has this disease made you? If it's made you very sick, then prognosis might be shorter than if you're just walking around absolutely living normally. The rate of growth and proliferation. So remember that Ki-67 index. The higher it is, the more active the cells are, the more aggressive we think the pace of change is going to be. Whether or not there's a hormonal syndrome, we talked about one, the carcinoid syndrome, and whether it can be controlled, very importantly. So patients with a hormonal syndrome, because these cells have hormones, if it can be easily controlled, do a lot better over the long haul than patients whose syndrome can't be easily controlled. The availability of multiple new treatment options. So not all these treatments that we have are available every place, every province, all the time. It's a big issue that you're going to be hearing about today at length, I'm sure. I just realized there's a prompter here for those of our colleagues who, there is a prompter here, so I can stop looking into the light because I'm already seeing basically nobody. The sensitivity of your tumor to different treatments. So we can offer all these treatments, but there's really no perfect way to match disease to treatment. Some patients think it's trial and error. It's hopefully a little bit more than that. It's educated trial and error based on a lot of data, a lot of clinical trial information, but for all of you who know, who go through multiple scans to check, to see, to monitor, we never know truly, is this going to work? How long is it going to work for? So there's always mystery. And other competing risks to your health. So again, we all focus on a new cancer diagnosis in terms of the cancer. But if you can imagine, if a patient comes with one of these diseases and also has poorly controlled diabetes, has had 3 strokes, a heart attack, and terrible rheumatoid arthritis, those other health conditions are really going to limit what we can offer and may, in the end, be more important in terms of prognosis than the tumor itself. All right? And all these factors factor in, and it's all different for everybody. Last couple of slides. Who is going to help take care of me? So does anybody remember this the Sufi fable of the 6 blind men and the elephant? Where you have six blind men approach an elephant from different angles. You know, I always joke that the medical oncologist always grabs the tail, you know, unfortunately. The endocrinologists are the smartest, so they go up here. The surgeons are the bravest, so they go in front of the tusks. But the bottom line is, these blind men all think they know what they're feeling. The oncologists think they feel a rope. The endocrinologists think they feel a fan. The surgeons think they feel a spear. And that's how it used to be. Everybody used to work separately in their own little caves, and all thinking they knew exactly the answer, didn't have to talk to anybody else. We know now that's absolutely not the way to deal with to help patients with neuroendocrine tumors. So there's a huge team behind any of us. And I list some of the people here involved, and not to minimize the multiple nurses that we always focus on the docs, right? But our nursing colleagues, whether they're surgical nurses, interventional radiology nurses, medical oncology nurses, play a huge role, and I think all of you can attest to that. We all provide our areas of expertise, but the key thing is that we need to be talking to each other constantly, whether it's in our centers, in our province, in the whole country, in forums like this. It's the only way we learn, the only way we advance, and there's lots of evidence that it improves care. Last question. This is the most important one. Everybody ready? What is a group of zebras called? Oh, amazing. The first one to ever get this. So, a dazzle, okay, which to my mind is the best word for a grouping of animals ever, a dazzle of zebras. So, Jackie, I think there's a door prize. So if I win it, she gets it, unless it's a car, all right, or a boat or something, then we'll have to just talk it out, okay? But apart from that, it's yours. Thank you very much, everybody.